Thank you, Dr. Ryan. The floor is now yours.
Okay, great. You all will be thrilled to know I am not going to be instructing you all in anything related to technology today. So that's the good news. What I want to do during the next 30 or 40 minutes is talk a bit about the ways in which indifference, diagnosing indifference is a component that we have to consider now when we talk about medicine and the clinical environment. So I'm going to give you several examples after defining some basic terms to show the ways in which health inequities creep into the medical sphere. And then I'm going to get into an example of an approach that was taken actually very far away in Africa that I think establishes a good model for how to deal with health inequities and, unfortunately, the indifference that some populations feel within a clinical setting. And I hope to end with some talking points, just some basic best principles that you can hopefully go out and share and that will guide your practice. So I'm going to be asking Kirk to actually go to the next slide since he is sharing the screen. There we go. All right, so I have three questions all related that I'm examining in this talk. The first is how we recognize healthcare inequities in clinical encounters. I think that we all hear this term almost on a daily basis if you read the news or you watch the news or you scroll the news on your screen. But the question is, what does healthcare inequity actually look like? And a related question to that is, at what point in the healthcare equation do healthcare inequities actually creep into the medical sphere? Where does it start, in other words? Does it start when someone walks into an examination room? Does it start when they're attempting to buy the prescription medicine that has been prescribed to them? Or does it happen at a different point in time? And then lastly, how can we, once we've recognized healthcare inequities, actually respond to them in a way that is respectful and a way that is appropriate for all parties involved? And I found this wonderful image online. It's actually a painting by a woman named Leah Saulnier. It's called Elephant in the Room. And I actually kind of chose it because I like the way it looks, this huge elephant pushing out the sides, the walls of this room. But I think that depending on your perspective, there is an elephant in the room when we have this conversation. Because on the one hand, if you've read my blurb, the PR release for this talk, you know that I'm situating the notion of health inequities and the indifference that can come out in clinical encounters in the context of a dramatically sophisticated, increasingly technologically driven medical environment. So I think that from the medical side, the medical perspective, one might wonder, well, we're doing all of these things with research and with clinical practice and with trying to help patients live the best lives that they can live, both within our institutional sphere and beyond it. But what more could we possibly do? And from the other perspective, individuals experiencing healthcare inequities, I think, are asking, look, you got all of this technology, you've got all of this sophisticated medicine. I hear about cures for all kinds of things, yet the people in my community are dealing with the symptoms of these diseases and they're dying at an early age. So there's this kind of tension. And like I said, I think the elephant in the room is a different elephant depending on which side of the equation you're coming to this encounter on. So Kirk, I'm ready for the next slide. Great, thank you. So I'd like to start by just defining some of these terms because I think they're often used interchangeably and they're actually quite different. First off, health inequities. Health inequities are defined by the World Health Organization, usually known as WHO, as the systematic differences in the health status of different population groups. And what distinguishes health inequity from health inequality is that health inequity factors are considered to be unfair and avoidable inequalities that would not be necessarily inevitable or natural, but they come about because of human behavior. So living in poverty, and the not only the social ills but also the physical and emotional ills that that creates would be an example of health inequity. Having an increased risk of mental illness because of the circumstances in which someone is living or the trauma that has been a part of their lives, that would be an example of health inequity. Health inequalities, on the other hand, are differences that are to a degree natural or are not necessarily avoidable. So, for example, someone who is diagnosed with an advanced stage of cancer who is 30 years older than another individual with the same cancer, the same diagnosis, may not fare as well because of the advanced age. And that's not something that we have caused or that was unavoidable. I mean, we're born, we live, and we age as a part of that process. The term health disparities means the different outcomes in terms of health that are experienced by individuals and populations. And those disparities can be influenced both by health inequities, the things that we can perhaps avoid with better infrastructure, with better use of resources, et cetera, and also by health inequalities, things that we aren't necessarily causing to happen, but do in fact influence the outcome on a given population of particular diseases. Okay, I am ready, Kirk, for the next slide. So there are a couple of other things that I think are part of this puzzle that you need to be aware of before we move on. One is that a key example of health inequities causing health disparities is something called social determinants of health. And I'm sure if you're familiar with the lingo that's used in medicine and in healthcare, you've heard this term before. Again, I'm using the WHO's definition. Social determinants of health are defined as the non-medical factors that influence health outcomes, the conditions into which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of human life. So if you've ever heard the phrase, your chance of living a long life or your chance of going to college and having a successful and secure life has more to do with your zip code than it does with anything else. That ties into the notion of social determinants of health. So we're learning more and more that people who experience a host of factors like ongoing trauma, food insecurity, lack of transportation to and from jobs, lack of jobs, employment opportunities, they carry a much greater burden of stress, chronic stress. Chronic stress contributes to inflammation in the body. Inflammation in the body can lead to a number of specific illnesses, including many forms of cancer. Also, the emotional, psychological kinds of effects of living in these environments are notable. And so social determinants of health really plays a significant role in who gets ill, why they get ill, how they carry a burden that maybe others who live in a different zip code or in a more secure neighborhood might not experience. Another factor that influences health inequities, and again, just as a reminder, we're talking about differences that are avoidable potentially. These are not just the natural course of events, but these are things that could be altered, could be changed. A second factor is provider-patient barriers. And what I'm referring to here are some of the gaps and the hidden biases that are prevalent in healthcare institutions, just as they are in society. So, medicine reflects society as a whole. So when it comes to conversations, when it comes to assumptions about patients, when it comes to what this would be a part of assumptions, but what a provider assumes a patient is capable of doing for his or her own health, or the kinds of products, whether it's medicine or equipment that a patient might have access to, those are all tied up in barriers, because if you make an assumption as to what is possible and you're off the mark, then the information that is provided and exchanged is not going to be the best. Okay, so Kirk, can you hit the return button again? All right, so I've been talking very abstractly and theoretically. What I'd like to do now is bring in a very concrete example. This is a very personal example for me. It pertains to my good friend, Edwina Sanders. Edwina and I, let me just give you a bit of backdrop before I give some facts about her particular situation. She and I met in 2009. She was living on the street. She was homeless, and she had been diagnosed with triple negative breast cancer in 2008. And when I met her, she was sort of ending one stage of her treatment. She was ending the chemotherapy that she had undergone at Cooper Green County Hospital here in Birmingham. I met her because I had gone to a local church that's about 12 blocks from my university office. It's called Church of the Reconciler. And they actually minister to primarily homeless individuals who are living on the streets of downtown Birmingham. And I had actually gone there to volunteer my time and to see what I could do to help. I ran into Edwina and a few other women and men who I found out had been diagnosed with cancer. And Edwina and I just clicked, and we became very, very, very good friends for 12 years. So with that in mind, I want to just go through some of the facts about Edwina's life. She was born in Birmingham in 1964. Her parents lived in a worker's cottage near Sloss Furnace. If you've ever been to Birmingham, you know that that's where they manufactured iron and steel for a long time. In fact, that's what the city of Birmingham sort of came out of. She was born into the throes of the civil rights movement. Obviously, in 1964, things had not gotten a whole lot better. Both of her parents were addicts. Her father was primarily an alcoholic. Her mother was an alcoholic and also abused drugs. The kids, there was a total of 6 children. She had one brother and 4 other siblings who were female, who were sisters. And she told me so many stories about, they didn't have heat. They didn't have food. So the kids learned at a very young age to steal for what they needed. In fact, when one of the workers' families moved out of the cottage that was next door and no one else was coming in, Edwina and her siblings started tearing the wood siding off of the house to feed the, I can never remember what this is called. I want to say Big Boy, but that sounds like the name of a restaurant, but it's some kind of like furnace sort of thing that they would put the wood into. She completed 10th grade. That year, she was raped by a man who lived in her neighborhood. I had been riding around with her one day, and she took me to the neighborhood, and she showed me exactly where he had stopped and drug her into the car, and she was raped. As I mentioned, she was diagnosed with triple negative breast cancer. And one very important piece of the puzzle that I always forget to add is that I too was diagnosed with triple negative breast cancer when I was 29 years old, and that was in 1993. So I have now lived almost 30 years following that diagnosis and another diagnosis of breast cancer of a different type. But one thing that was different in Edwina's life is that she also suffered from comorbid diagnoses. She had COPD. She'd been diagnosed with heart disease. She was morbidly obese on the BMI scale. What you can do with that, what you will. There's a lot of controversy over that BMI scale. She had severe bouts of depression. She had, prior to me meeting her, been quite addicted to crack cocaine. And by the time I met her and she had embarked on her breast cancer journey and undergone treatment, she had kicked that. I never saw Edwina use any sort of drugs other than the ones that were prescribed to her. And in 2021, she passed away in her sleep. And I was not there with her, but what I can tell you is that her family did call emergency services, and it took so long for the ambulance to make it to, by now she was living in the West End of Birmingham, which is a very impoverished area. She didn't have a chance. She had been gone for some time by the time the ambulance arrived. You can switch to the next slide, Kirk. So those are all the kinds of facts that, might be collected by a physician who's taking soap notes, just figuring out who this person is and what her diagnosis has been and where she lives and that kind of thing. But there was a lot more to Edwina. She was incredibly funny. She was a character, and she and I had a lot of amazing times together. She was really sensitive, and she knew that people made fun of her. They pointed at her on the street. She would go with me sometimes into restaurants or into stores or into places that she never would have been allowed inside the door of by herself. And she knew that people stared at her and, made fun of her ill-fitting clothes and made fun of the dirt that was streaming down the front of her blouse. And she was hurt. She was incredibly sensitive. She was hurt by doctors and nurses who sometimes made remarks to her that were meant to put her in her place. And I'll share those, a couple of examples of those in a minute. She was incredibly maternal. All of the kids on the West End called Edwina Auntie. She was the auntie. They ran to her place, and they loved to sit on her lap, and she loved to fix the hair of the little girls and put it in pigtails, and just she was a very warm and loving person. She was scared a lot. She was not perhaps book smart. As I said, she only passed through the 10th grade, but she knew where she stood on the continuum of healthcare. She knew that she was going to the free hospital for poor people. She knew that her doctors were not overly enthusiastic about treating her and often questioned her multiple times when she came forward with something like complaints of pain. And she had a very strong feeling that eventually she would pass away and either no one would notice or they would notice too late. And truthfully, that's what happened to her. I can tell you one brief story, that sort of puts this in perspective. When Edwina went in for a mastectomy, she had actually already completed chemo, and she asked me to go with her to the hospital that morning for the operation. And she laid on a gurney waiting to be wheeled in. This was also a Cooper Green, and she wept, holding my hand and weeping because she believed that they would put her to sleep and forget to wake her up again. Edwina came from a time and a place that bred distrust in the medical system and white doctors. And at Cooper Green, the majority of the doctors were in fact white. There were some Black nurses, but I think I met one Black doctor in the entire time I went back and forth to Cooper Green with Edwina. But I asked her one time, I said, Edwina, why did you wait so long when you had a bulging bump on your breast for several years? Why did you wait so long to go to the doctor? And she said, Miss Ryan, in my family, when you go to the doctor, it's a one-way trip. And so she would say things like that. And I would realize how incredibly naive and how incredibly, but frankly, stupid I was. I had no idea. You can read about racism and medical care and a racist history and discrimination. But here was someone I cared about, and she was telling me point blank, this is how it is. One thing she used to say to me, and it's kind of funny, and she would laugh and I would laugh, but when I would say something, like make a suggestion of something that she might be able to do that would help her, she would say, Miss Ryan, you so white. And she wasn't just talking about the color of my skin. She was talking about the fact that I had no real perspective on the life that she had lived. So I guess, the overarching fact here is that she was my friend, and she very much felt like a sister to me. We traveled together. I would take her with me when I went to give presentations. We had meals together. We prayed together. I was with her at the hospital and doctor's appointments. I met her family. This is the kind of relationship that we shared. So you can turn to the next slide, Kirk. All right, so Edwina's experiences exemplify the toll of health inequities. And again, as I said, I always had the conceptual ideas down, right? What health inequity was and what discrimination was and that sort of thing. But with Edwina, I sat by her. I still wasn't her, but I sat with her and by her as she experienced these things. So there were two ways in particular that I saw the toll of health inequities in her actual clinical encounters. The first was in messages about compliance. And compliance is really just referring to any prescriptive advice that's being given to a patient by a healthcare worker. So, Edwina was considered, on the one hand, to represent someone who had had a pretty rough life. She had lived through some difficult times and was still living through some difficult times. But in terms of prescribed messages that were conveyed to her about what it is that she needed to do to keep her health in as good a shape as possible, she really was treated like any body, right? Her body could have been the body of someone who had access to every imaginable device and medication and food that was possible. So there was a disconnect there between, no, she's not like us, but I'm going to tell her what to do as though she is like us, and us being the standardized norm. Just a few examples here. I was with her at one point when a doctor preached, and I use the word preach intentionally, preached to her about getting more exercise. And first off, Edwina had incredible pain, and that was difficult for her to exercise in the first place. But in her neighborhood, there were daily shootings. In fact, to the point where at dusk, she would move away from the window. I should have mentioned earlier, she actually, I helped her to get into a housing unit. So she did eventually get off the street, and she was in this small apartment where several of her family members lived with her. So there wasn't room in the apartment to actually get any kind of exercise. But to get out in her neighborhood and walk, she would have risked being shot. The doctor told her on another occasion, this was actually a different doctor, that she wasn't eating right. She needed to eat healthy foods. Well, unless I went with Edwina to a grocery store and helped her with her groceries, she bought food at the gas station. That's all that she had within walking distance from her apartment. Occasionally, someone in the family had a vehicle that she could work in or she could drive, usually illegally, because they never had money to pay for insurance or other kinds of things that were needed to actually operate the car. There's not a lot of healthy foods at the local gas station. Medications and devices. This was one of my favorite conversations. Edwina was in the hospital for COPD at this point in time. And a doctor came in with a group of interns or residents. I'm not actually sure what the status was, but Birmingham has a lot of medical students and people who are in training. And the doctor scolded her for smoking. And Edwina did smoke. She smoked cigarettes. And the doctor said, you need to get patches. And Edwina just looked at him and she said, I can't afford patches. And he said, well, but it costs you a whole lot less than buying those cigarettes that you buy. And I said to the doctor, what you don't understand is that to buy the patch, she has to have a chunk of change at one time to hand over for the patch. A cigarette pack, not that they're cheap, she can buy for a lesser amount of money. So in her mind, the cigarettes are affordable and the patch is not affordable. Plus, it requires that she have steady access to, say, pharmacies and places where she could get refills on the patch, because she's certainly not going to pay ahead and get additional ones. Transportation, I already mentioned that. So, the toll in terms of compliance is that it was very rare, and there were physicians and healthcare workers who did try to understand things from Edwina's point of view. But there was certainly more of a focus on prescribing, telling her what she needed to do, which was packaged in the same way as it would be for any patient from any circumstances. Then in describing, okay, what are your conditions? What could we do, given that there may be weeks where the only place you can go to get food is the gas station? Well, what could we do? I will tell you that in her apartment complex, many of the neighbors came together and they tried to start a community garden, and they loved it. Edwina absolutely loved it. But the 2 weeks into the first harvest of some vegetables, people were stealing what they had grown. So that backfired. But again, it was this focus on telling someone what to do in the context of an ideal world for a patient, as opposed to recognizing the circumstances in which she dwelled. You can shift it again, Kirk. So the second component in terms of the toll that health inequities took on Edwina was in the tone that was used to convey this advice about compliance and what was happening to Edwina's body. First, there was the physical divide. On more than one occasion, I saw physicians, and I've had this in my own encounters in a clinical environment, turn around and not look at Edwina, not touch Edwina, not make eye contact with Edwina. That's just bad practice generally. But when you're dealing with someone who greatly mistrusts or distrusts the institution and the individuals within it, I think that anything that could be done non-verbally to kind of make the situation more comfortable is what you would want to aim for. Other tone issues, I've already mentioned these, but scolding tones, speaking to Edwina as though she was a child. She wasn't a child. She was about a year younger than I was, and but she was treated oftentimes as a child. A lack of recognition of her not trusting what they had to say, but also oftentimes healthcare workers not trusting her. Edwina had so many comorbidities. She had severe arthritis, osteoarthritis. She had a cane. She eventually ended up in a wheelchair because the backs of her legs and her back were in such poor shape that she couldn't really even stand for any sustained amount of time. She would tell the doctor this, and one of his immediate, and I say his because with the exception of one female doctor, almost all of the doctors that she saw when I was with her were male, said, well, I don't know. You know, you have this drug history. I'm not sure I can give you any kind of a pain medication. And, you know, again, I understand that she did have a problem with addiction years before, but she desperately needed pain medication. I mean, she needed it. And after a while, we got, you know, we got kind of constructed an argument so that the physician realized that he could keep a very close watch on her. She could come in if she could get there transportation wise to have, you know, to have urine tests and that kind of thing so that he would know she wasn't abusing the medication. And then the last sort of tone issue, which is part of the title of my talk, is just indifference. A kind of, well, you're the kind of patient that we give up on. You know, you don't follow any of the advice that we give you. You're living in an unsafe neighborhood. There's no hope. I can tell you that one of the most disturbing things I ever saw with Edwina was when she was being wheeled in for a mastectomy, and her doctor, a white female, walked past her numerous times. Edwina was lying there weeping, howling, weeping, holding on to my hand, holding on to one of her sister's hands. And the doctor never stopped to offer a kind word, never smiled at her, never assured her, never touched her hand. And it was appalling because I've never been in a pre-op or a post-op or any clinical environment where I didn't have that kind of respect. Okay, you can change it again, Kirk. So I want to talk just very briefly, and I'm kind of going to gloss over this stuff and I can go back to it later if someone has questions. But I think that there are a few underlying influences and frameworks within the medical field that contribute to these types of behaviors. And I recognize as I'm saying this, and I'm sure someone's going to ask this question, you know, I clearly have a bias as to how things played out with Edwina. Because this is what I experienced. This is what I witnessed and saw with my own two eyes. Obviously, there are numerous examples of these kinds of interactions not existing, and of doctors being overwhelmingly concerned with individuals, regardless of the environments from which they come, or regardless of their ability to comply with prescribed advice. So I just want to sort of make that adjustment. And I know it may not come across in that way, but when I talk about Edwina, I just get very passionate and I'm brought back to those experiences. So again, a few influences and frameworks. The first is this notion that medicine as a discipline is actually unified. All this means is that there is a notion in this culture, within the medical profession at large, that medicine is all-knowing. You go to medical school to figure out how the body works definitively. You go to medical school to understand all of the different diseases that can afflict someone. I mean, this is the explanation behind that old joke of you go to a party, and when somebody finds out that you're a physician, they start asking you to look at, the weird growth behind your ear, assuming that, of course, they're going to know they're a physician. And so Berg and Moll both talk about the fact that that's not really how it is. I teach medical students. I teach mostly pre-med. So they're getting ready to go on to medical school. And we talk at length about the fact that medicine is an art. Medicine is a critical thinking kind of endeavor, that what medicine is not just a body of knowledge. It's training in how to think about things and to try to problem solve, but you don't always have the answers. A second assumption that greatly influences all that I've been talking about is assumptions about provider objectivity and neutrality. And this is just the notion that a healthcare provider supposedly turns off any blinders, right? The healthcare provider is able to look at the body and the person who walks into the examination room or who is lying on the operating table from an objective perspective. They see the disease as a whole, not the person embodying the disease in a way that would affect what they think can be done for the patient. So that's another assumption that greatly affects, I think, the sort of interplays that I saw over the years that I spent with Edwina. You can switch to the next slide, Kirk. Another influence, and I've mentioned this a bit, is the notion of the universal body. What this means is that, there is in training people how to be physicians or how to be nurses. There is a sort of standardized patient that is being conceptualized. So, I give the example here of the standardized patient programs. Now, those have evolved a good bit, but standardized patient programs are those kinds of, well, I mean, they're programs, but they're a sort of approach to teaching medical students and nursing students how to interact with patients. And so what someone does, an actor comes into an exam room and exhibits certain stereotypical symptoms that would accompany a particular diagnosis. And so the students then interact with this individual, and the goal is to get it right, to figure out what kinds of tests they need and what sorts of diagnoses this particular patient could be showing the symptoms for. Classifications of diseases, what's called the nosology. Michel Foucault writes extensively about this. Again, is another concept of we can somehow map all of the diseases. We can figure out, oh, these are respiratory diseases. These are types of cancer. These are different sorts of neurological afflictions. And those are all very helpful because they help us to figure out, how to approach a patient, how to treat a patient, to look at past cases and what has worked and what hasn't worked. But they're also a kind of a classification system in flux, because sometimes something that we thought was one thing, belonged in one category, actually is something else. I'll give you an example that many of you have probably heard of. Warren and Marshall, two physician scientists, I think this was back in the 1970s. Everybody in the medical profession was talking about ulcers and treating ulcers as something that formed as a result of stress. So when someone came in and the doctor suspected an ulcer, the patient would be asked all kinds of questions about, their daily life and how do you handle pressure and do you work a lot of hours and, are things good at home and that kind of thing. Well, Warren and Marshall came up with the idea from lots of cases of patients and lots of observations that ulcers weren't really about stress. They thought it had something to do with bacteria. And they were right. Ulcers typically, maybe always, I'm actually not sure about that. I'd have to go back and look at the research. But ulcers form when there is too much stress on the stomach from a bacterium called H. pylori. And so it's bacterial in nature. It's not a result of stress. So that would be an example of the nosology shifting when new information comes in. And there's a whole story there. Warren and Marshall drank the Kool-Aid and gave themselves, unprecedented amounts of H. pylori, and then they got ulcers. And anyway, but eventually they won the Nobel Prize because they actually figured out how. Even over-the-counter advertisements, the assumption that everybody is the same, right? So if Serena Williams, who is certainly not everybody, she's got a whole lot more athletic talent than I would ever have. If she takes this medication and it knocks out her migraine, then it's going to work for everybody else too. Okay, and you can switch the screen again, Kirk. All right, and then two more assumptions. One is that bodies that defy universal standards and truths then are considered abnormal. If your body doesn't look like everybody else's body, I mean, think about cosmetic plastic surgeon advertisements, right? Your nose is a little outside the norm in terms of size or shape. We can offer a service so it looks like everybody else's. A guy named Hoberman wrote in 2012 that actually this is what the racializing of the Black body is about, is that because individuals who have Black and brown skin look different, it's easy, or has been easy historically, to determine that there was something abnormal about the way these individuals looked, and by extension to make assumptions about other things going on in their physical and mental selves that might be associated with these differences. So for example, there is folklore in American society and British society that says that Black skin is actually more what's the word? It's sturdier. It can withstand more than white skinned. So meaning that whites, by extension, are far more sensitive than are Blacks. Notions of Black athleticism. I mean, I still hear this kind of thing today in 2023, where someone will slip up, some sports announcer will slip up and make a comment about, the anatomy of a Black athlete and phrase it in such a way that it assumes that Blacks are simply better basketball players, better football players, what have you. Black pain. Black women were among the first, actually women who were slaves were the first test subjects for a lot of modern gynecological approaches, and we're not given pain medication. We're not sedated because, well, they're different. They're abnormal. They can withstand the pain. And then finally, I assume that, again, many of you have probably heard of this, that there really is quite little recognition in medical school that there's a need to have a very integrated, sustained approach to training the next generation of physicians and nurses and all manner of healthcare professionals in how these prejudices and biases feed into the practice of medicine. And so most med schools, I know that this is true at UAB, the students have a cultural competency unit. Cultural competency meaning we learn that other cultures have different values, different rituals, maybe different attitudes and thoughts about medicine, and then they're done with it. My daughter just finished nursing school at Auburn, and she actually showed me the book and the module that she had to take for nursing, and that's what it was. And she said to me afterwards, she said, Mommy, I think that if I had not met Edwina and had not gone with you to, work with people who are so different than we are, I wouldn't have known anything. I mean, she said that cultural competency training was a joke. I mean, it was like learning terms, but not actually being immersed in another culture. So I am going to end with an example of what I think does work. I've been kind of bashing and talking about all the horrible things that I witnessed. And so if you want to change to the next slide quickly, Kirk. So I think that what's important to note is that, Rome wasn't built in a day, right? Sure, you never heard that cliche before. But whatever changes might occur, they have to occur very slowly and gradually. I mean, you'd think after the amount of time that we've been on planet Earth, we would have made a bit more progress in some of these areas. But I know now in retrospect that a lot of my impulse as Edwina's friend to go to appointments with her because she wanted me to go with her and to advocate for her and to speak for her, that wasn't always probably the best thing that I could do, because it almost assumes that Edwina had nothing to say for herself. And, sometimes I would kind of go at it with the physician and, there would be grumbling and, we'd finally come to some kind of resolution. But that's not the answer. And I'm not saying we shouldn't advocate and we shouldn't, extend ourselves into other communities. I think we should, but I'm not sure in what way exactly. What I believe needs to happen is that we simply need a different approach in medicine. We need to not stick with cultural competence, that's one unit, but we need to embrace a notion of cultural humility. Cultural humility is recognizing that you're never going to understand somebody else's life, but you need to try. So it's the idea that the learning never stops. And the best you can do is you can try to familiarize yourself and be a part of a variety of communities, meet people from different places with different lives and with different kinds of factors influencing their lives, and value that difference. Don't turn your nose up at the difference, value it, see what's there. So I'm going to give you a very concrete example. So Kirk, if you could switch the slide. This one we're going to spend 2 seconds on. The example I'm giving you comes from Zambia. And I just am presenting a map of Africa, and Zambia is down there in the kind of, I guess it's a magenta color. So it's the southern portion of Africa. So you can switch to the next slide. Okay, so I was in Zambia in 2010. And so everything I'm talking about right now is situated in 2010 because I don't have current data. I know things have improved as a result of the program that I'm going to tell you about, but I don't know what those numbers are. So I just want to be very transparent about that. Zambia has a population of around 32 million women. And when I say women, I mean girls who have reached puberty and above. And the way this population count was determined was by looking at girls ages 15 and up, even though many women really all over the world, reach puberty at earlier ages now. Cervical cancer is the most frequently diagnosed and deadly cancer among Zambian women. And I just give you a comparison here. In America, about 8 of every 100,000 women are diagnosed with this cancer annually, and about 1 or 2 of them will die. And all of this is because of the pap smear. We have a means for detecting the early lesions that signal the possibility of cervical cancer. And so women are treated early on. I mean, it's almost unheard of when someone has an advanced case of cervical cancer or, heaven forbid, dies of cervical cancer. In Zambia, it's 53 of every 100,000 women, and 39 of those 53 women will die from the disease. Big problem. I actually spent some time at the University Hospital in Lusaka, which is the capital of Zambia. And the floor that I was on, the cancer ward, which was part of the maternity hospital, actually, because there wasn't a cancer hospital, was filled primarily with women who had advanced cases of cervical cancer. There are reasons for this health crisis. I mean, there's not a lot of knowledge of the symptoms of cervical cancer, and women also tend to not have transportation to get to clinics to have testing. Also, they tend not to have the extra time. Many women have multiple children once they're married. And all of these are affected by social determinants of health in terms of low education levels, living in poverty, food insecurity, all of those kinds of things. So, Kirk, do you want to switch to the next slide? So those were just the facts, just like I gave you just the facts about Edwina. But I want to tell you about the beyond the facts, what's really going on in Zambia. The reason women do not report symptoms that they do notice and do not get them, checked out or have them treated is that cervical cancer is greatly stigmatized in Zambia. There is shame associated with it, and there is terrible punishment. And I observed some of this while I was there. The stigma is that if a woman has cervical cancer, the assumption is that she got it through sexual activity. And if she got it through sexual activity, it must mean that she was not faithful to her husband. The problem, according to the physician that I spoke with in writing this story, is that 9 times out of 10 in this culture, the men are the ones who are giving the women the virus that's then causing cervical cancer. The shame is associated with them not being the kinds of mothers and wives and women that bring pride to their communities. So the punishment for women diagnosed with cervical cancer many times, not always, but many times, is divorce, being expelled from the home, having one's children taken away, and sometimes even completely disregarding them, treating them almost like like lepers. I mean, no food, no provisions, no anything. When I was in Zambia on this cancer floor that I was talking about, there was a very young woman, probably, I don't know, late 20s, and she was in a room. She was dying of cervical cancer. She died during just the few hours that I was on that floor. And the entire time she was dying, she was speaking in a language that I don't understand, but she was saying to the woman who was translating for me that she just wanted to see her children again. Her children had been taken away. Even her own mother wouldn't speak to her because of the cervical cancer diagnosis. This was a story, an investigative story that I wrote in 2011 about this experience, and it was published in Cancer Today, which is published by the American Association for Cancer Research. So you can move to the next slide. All right. So I want to talk about what happened in Zambia that has turned things towards the better, hasn't fixed these problems, this high incidence of cervical cancer and the dire outcomes from it, but has certainly helped. In Zambia, in Lusaka, there is a place called CIDERS. It's the Center for Infectious Disease Research, and it's actually affiliated both with UAB, my institution, and the Zambian Ministry of Health. And there's a guy there. His name is Dr. Grosbeck Paran. He is trained in OB/GYN, and he's lived in Lusaka for many, many years now, a few decades at least. And when he went, he learned of this incredibly high incidence and toll of cervical cancer on Zambian women. And so he worked with a number of people and he got a program underway. And the program is absolutely brilliant. It has two layers. The first layer I'm going to talk about very quickly. And then the second is where it really strikes me as something just genius. The first thing he did is he realized, the women in Zambia can't, for a number of reasons, take the time away from their families to go to a clinic to be screened and then go back a week later or a month later and get the results, and then go back several times after that to be treated for what could be cervical cancer. They also distrust men. They distrust the male doctors. They're more comfortable with female doctors or female nurses. So what he did is he worked with others who had already kind of modified westernized medical standards for people in developing countries. And he started to open up clinics that used what's called VIA, which is visual inspection with acetic acid. Basically, in a single visit, a woman has a kind of vinegar applied to her cervix. A nurse takes a picture of what shows, because the vinegar will actually affect the cervix and show any lesions that are apparent, sends the picture of the cervix to a doctor, a male doctor with no name, no identifier for the woman, the patient. That doctor says, you know what? Actually, I think these are early lesions. Let's treat her for these precancerous lesions. So they give her cryotherapy. I'm not exactly sure what this is. It's a type of treatment where they can kind of zap in the office that day these lesions. And then they like to have the women come back again, but they recognize that in most cases they will not. So a woman can slip away, even take her children, get to one of these facilities. She's no longer met by a male physician who she fears will blame her and shame her. And she can be diagnosed and treated on the spot. And if she is unable to come back, at least for that visit, those precancerous lesions have been taken care of. So that's a good move. The other part of this program, though, is absolute genius. Grosbeck knew that if he brought in the team of highly trained Western doctors to talk to families and to talk to women and to try to change the culture around cervical cancer, to get them to abide by the kinds of guidelines that are used in developing parts of the world, it's not going to work. So what they did is they recruited women who go by the title Alangizi. Alangizi are like midwives, wise women in the villages who have what's called kitchen parties, which are kind of like bridal showers and baby showers and these other kinds of parties for women who are at various stages in their life's journey, whether they're getting married or they're having their first child. These Alenghizi are trained to talk to the women who come to these kitchen parties about cervical cancer, how you get cervical cancer, how it's not something that you have to be ashamed by, how you can discreetly go to a place and have your cervix looked at and treated without ever involving your husband. And they slide it into the advice that they're giving about how to get along with your mother-in-law and how to, cook your husband's favorite meal. The cervical cancer rate, the last time I checked was around 2016. I checked in with Grossbeck. He was at a conference I was at, is going down dramatically. And so last slide, please, Kirk. The point of all of this is that medicine is or should be a science. And if you really acknowledge and embrace difference, rather than treating patients who are struggling or who are different, whether it be culturally or physically, they have kind of anomalies in what they present with. The goal should be to treat them where they are, to give them the respect to acknowledge that they're not just anybody. They're not just, this kind of generic patient who should get the same advice and the same treatment as everyone else. They deserve respect. And one of the individuals that I spoke with and cited in this article for Cancer Today is Paul Blumenthal, and he's the one who actually came up with the VIA method, the use of acetic acid. And he told me, he said, when you're working in the developing country, that I always remember anything you do in life has strengths, benefits, limitations. Good is never the enemy of the best. And I think that has stuck with me, because I think that what happens in medicine is as we progress and become so sophisticated and so technologically reliant, we forget that we're leaving so many people behind. And Blumenthal is saying that's not okay. And to figure out what works for the individual patient and to treat them with respect and acknowledge, the limitations that they're living with, and to praise them for the things they're able to do within reason, within their environment, to be the healthiest and happiest people that they can be. That's great progress. It doesn't have to be the westernized standard. And I would have given anything for Edwina to have experienced that. But unfortunately, she didn't. And so I think that I'm going to spend a lot of time in my life trying to figure out how to not repeat that with those who come after her. So, Kirk, there is actually one last slide. I'm not going to go through these, as I know time is getting really tight, but these were the best practices. And, I guess I'll just leave that up on the screen. These are things that I've mentioned numerous times throughout the presentation. So thank you so much. And I'm happy to answer questions in the time that remains.